Okay, hello everyone. My name is Leena. I'm a second year medical student with you guys. I had previously done POD OSPI review and as well as neuro OSPI review 2 days ago or 3 days ago, I think. I just want to start with عيد مبارك، كل عام وانتم بخير، وكلها كم يوم وإن شاء الله تهون علينا والله يوفقنا وييسر لنا أمورنا يا رب. So today's going to be a kind of a sweet and short session compared to everything I've done in the past. I basically will be giving some practice SAQ questions and kind of go back to the lecture of each case we get in the question and kind of remind you of these slides. As well as some high yield pathology. You know how like we have Guillain-Barré syndrome and so on. I'm going to talk about these specific cases just as a reminder, even if it's not question-based, because, I can't put everything in question form. Inshallah, it's going to be helpful, and please be interactive. It's very much a Q&A type of session. So, yeah, let's go ahead and start. Bismillah. And also, I just want to mention, please let me know if I make any mistakes. I tried my best to make sure that I have all the information right. But if something slipped my mind or I got confused, please feel free to correct me, unmute yourself anytime. And yeah, okay. So the first case we're going to talk about is a meningitis case. Then we're going to talk about kind of all the possible organisms that can cause meningitis, that's acute meningitis, because that's likely to come in SAQ. A brainstem lesion. Obviously, you can only imagine how much I can't bring up all brainstem lesions, but I will help you learn how to dissect a question in order to know where exactly the lesion is. Then you'll have a psychiatry case, a dementia case, or kind of a pathology case, and other high-yield neuro cases in the sense they're more pathology-based cases. So let's go ahead and start with the meningitis case. So a 6-year-old baby suffered from meningitis. A lumbar puncture was taken and a culture with the bacteria and culture of the bacteria. He had rashes all over his body and hands. And you can see these are the two figures they give. This is what the culture looks like, and this is what the rash looks like. Okay, so let's go ahead and answer these questions one by one. So can anyone volunteer to unmute themselves for the first question? Name the genus and the species of the bacteria. Any volunteers? So just know based on the presentation of the rash and the specimen over here. Does anyone have any guesses? Let's interpret the picture. It's a gram negative because it's pink. Okay. We have petechial hemorrhagic rash. Do you have any bacteria in mind that can cause this type of hemorrhage? Yes. So it's Neisseria meningitis. So this is the genus Neisseria meningitis. Like, what is the contraindication for LP or lumbar puncture? High intracranial pressure. Perfect. What is the drug used in treating the patient? So in the case of an antibiotic, herniation, you're completely correct, is another option of a contraindication for LP, and we're going to go more in depth about all the possible options. What's the drug used in treating the patient, as in for this case, ceftriaxone? What's the mechanism of action of ceftriaxone? Don't worry, we're gonna go in depth as to why each one is this answer. بس do you have any كده memory of why it's ceftriaxone? What the mechanism of action is? So ceftriaxone is a third generation cephalosporin, and it's basically a beta-lactam. We'll go more in depth with it now. Describe the prevention method from getting the disease. So if you are surrounded by people who got this disease, what would you do? Okay, it's okay. We're gonna go over the answer. It's okay. Mask, that could be a preventative measure, but what we're looking for is something more long term rather than يعني, when you already have been exposed to, yeah, vaccine is more long term. And if you're already exposed to it, mask would be like kind of too late to be sorry. Um, so you would be focusing more on prophylactic antibiotics. And we will talk about the two options that are usually mostly we use as a prophylactic for any type of meningitis if you ever can get it. So I just want to كده say a story about myself. Maybe that'll help you remember in the exam. My cousin, my baby cousin got meningitis when he was a baby. So me and all my cousins, all my family members had to take prophylactic, even if we didn't have any symptoms. And all the pharmacies ran out of the antibiotic that I will mention now in a few slides. So you will have to remember that all the Eastern province ran out of this antibiotic because all my family members had to take prophylactic. So this is a nice way to remember that prevention method, if you're already surrounded by someone who got meningitis, is prophylactic antibiotic. And for future prevention, it would definitely be vaccines. Give three symptoms that would signify meningitis. And fever is high yield in almost every type of infection. So imagine if it's not accepted in the answers. What's something unique to meningitis? Headache, 100%. There's like this specific symptom that's so high yield in so high yield everywhere. Meningitis equals neck stiffness, 100%. Perfect. One more. It's a sign. You always say this sign, and pro. It's an examination, physical examination. Take a hard guess, yalla. So I don't know if you, yes, Brudinski and Krinsky sign, Kring sign, yeah, exactly. And we will talk about what they are, but yes, these two signs are indicative of having meningitis. Give three factors in a CSF table that would be given in an exam that would indicate that it's bacterial, not viral, not fungal. What makes it specifically bacterial? Low glucose, high protein, and one more thing. Actually, we can say, yes, high neutrophils, and one more thing, turbid CSF. It's not turbid counts. It's the color of the CSF would be turbid, زي or like ترابي. الكلمة هي ترابي. Okay. What is the mode of action of ceftriaxone? This is kind of a repetitive question for what would you use? Uh, yeah. Turbid 100% counts. Yes, that would count as well. So what the drug is used for patients, we said we would use ceftriaxone and or a cephalosporin. Ceftriaxone is a type of cephalosporin, and we said the mechanism of action of it is basically it's a cell wall synthesis inhibitor. Specifically at which step we will mention in the next slide. The patient was given a vaccine later. Okay, what is the most important part of the vaccine? Imagine, the case was strep pneumo. Okay, you know what? I will leave this question for later when we talk about strep pneumo, and then we'll talk about what's the most important part of a vaccine, and specifically the vaccine of streptococcus pneumonia. Because what I basically, yes, exactly. The answer is a polysaccharide capsule. And basically, the reason why this is the answer, first, let me just mention why I put this question. I tried to collect all the questions that could come in a microbes SAQ. Okay, and this question applies to if the case scenario was streptococcus pneumonia. And in streptococcus pneumonia, the way they created the vaccine is by taking the antigen from the capsule. So you're not actually taking strep pneumo, you're actually just taking the antigen of the capsule in order to stimulate the immune system and create a kind of a long-term like يعني protection for the body or immune response. Okay, so name the genus and the species of the bacteria, Neisseria meningitidis. Okay, we know this. Like, what's like some other كده things that you have to have on the top of your mind when when you're talking about this? First of all, it's a gram-negative diplococci, as you can see, and they always say it looks like coffee beans. So gram-negative intracellular diplococci, where will you see them? Inside PMNs or polymorphic neutrophils. Okay, was it polymorphic neutrophils or basically neutrophils? Um, uh, and it's diplococci, so they come two pieces together like coffee beans. It's oxidase positive. This is something kind of in lab that you should know. You should know that most Neisseria meningitidis that actually invasive that and causes you severe meningitis are encapsulated. So there are forms of meningitis of Neisseria specifically that is not encapsulated, but the actual things that are causing that severe reaction is polysaccharide. And as you remember from POD, a polysaccharide capsule makes the antigen clear for us. That's how we can create a vaccine. That's how we can know which specific antigen of Neisseria meningitidis or subtype it is. Spread by droplets. So make sure you know how the difference between droplets and aerosols. Aerosols are كده, they can spread at longer distances. Droplets is like accidentally talking and spitting something out, or for example your nose droplets or something, your tears, something that actually has weight, as you can see in this picture. So you kind of have to be in more close contact than airborne. Okay, so droplets and so you can, even by kissing someone, saliva and all of these things are considered a way to spread. And the way it usually comes in this area where you're overcrowded space, like a student's campus, like a student's dorm rooms, like a lot where they're sharing a lot of rooms, military spaces where there's like a lot of people in the same place, it can spread easily. So overcrowding is a key word that you will see in a scenario. A very high yield like thing that you might want to notice in these questions is kind of the manifestation it comes with. Not only the picture of the slide or the micro slide. No, when they say hemorrhagic skin rash, non-blanching hemorrhagic skin rash, which is the picture I show you here, this is very, very unique to Neisseria meningitidis presentation. Every single bacteria that we're going to talk about have something unique that they will say in the specific scenario that you immediately can know without even looking at any picture. So in the case of Neisseria meningitidis, it's actually the hemorrhagic skin rash, or as you can see over here, the petechia and purpura. You may also have a complication of bleeding of the adrenal gland causing adrenal insufficiency, also known as Waterhouse Friderichsen syndrome. So basically, this is a complication that can happen, or multi-organ failure. Let me take a picture of so that you can see specifically what non-blanching. I want you to visualize it. Okay, so basically, let me. Okay, so when you have a blanching rash, oh, you can't see my screen. Resume share. Oh, okay. So when you put this type of pressure and the rash disappears, it's called a blanching rash. So when you put pressure, the rash disappears. I'll show you here the definition from Google. It says if the rash disappears with pressure, it's considered a blanching rash. If the disappear does not disappear, it's considered non-blanching. So you see this test over here. When they put this pressure, the rash kind of distributed and it got pressure and it disappeared. But over here, if you, in our slide, let me share back the slide. Okay, over here, no matter how much pressure you put, it won't be removed. Okay, clear, good. So this is kind of the kind of a reminder of Neisseria meningitis, I wanted to show you the epidemiology, because from the age, you can know so much. You can know so much because it says 6-year-olds now, okay? Over here, you'll see 1 month to 2 years to 18 years, most common is meningitis, okay? So newborn, you see newborn baby, algalactiae. 1 year to, 1 month to 2 years old, strep pneumo. 2 years to 18 years, which is kind of like, think of people at school, Neisseria meningitis, because of droplets. They don't have this cleanliness. 19 to 60 and 60 and above are also strep pneumo. So strep pneumo is also a high yield concept that I also wanted to explain, even if it wasn't necessarily the question, because you can see that most age groups are susceptible to strep pneumo, except newborns, algalactiae, and school age. Let's think about it as school age from 2 years to 18 years until you graduate from high school, you have a high chance of getting Neisseria meningitis. Something else I want you guys to know is that the virulence factor. All of them have capsule, IgA protease, pili, endotoxin, outer membrane protein, except strep pneumonia doesn't. It's kind of weak. Although we said it's common, it's a little bit weaker. It doesn't have pili, it doesn't have endotoxin, it doesn't have outer membrane protein. You just have to know it has a capsule, which we use actually for the vaccine, and it has IgA protease. Okay, so can anyone tell me if they remember all these virulence factors, or do you want me to remind you what a capsule is, what IgA protease is, what is pili, what is endotoxin, and what is outer membrane? Does anyone have any كذا want me to remind you of a meaning of one of them? You know what? Maybe people in the recording want to remember. A capsule is basically a glucose layer around the bacteria, which makes it easier to go from one place to another. And also, when it's a capsule, it's hard for our cells for our immune cells to actually hold it together. It's hard for something called opsonization. And what opsonization is in the immune system is basically putting a fork inside a piece of meatballs. Okay, imagine you're putting a fork inside a piece of meatballs. When you put the fork, you can remove the meatballs without holding your hand and creating a mess. But when you have a glucose layer around the bacteria, no matter how many times you put the fork, it's sliding from the fork. You're not actually holding on to the bacteria. So this glucose creates this slimy-like texture. So it's hard for our cells to opsonize it or hold it or grasp to it, okay? So in strep pneumo used in the vaccine because it's the weakest. No. I didn't say it's the weakest because related to the vaccine. We use the capsule because it has a capsule. We use the capsule to create the vaccine, but it is considered the weakest in comparison to Neisseria meningitis or H influenza and strep pneumo because it doesn't have as much virulence factors, because it doesn't invade the immune system as much as the rest of the bacteria. Does that make sense? But the vaccine part isn't related to the virulence. I'm just saying they're using one of the virulence factors, which is the capsule, in order to create a vaccine, not because it's the weakest or anything. Yes, they either have capsules, but they might use other vaccine creation methods. Strep pneumo أصلا vaccine is kind of newer than the rest. So as far as I know, يعني the way so H influenza vaccine and Neisseria meningitis vaccine, they didn't mention that it's created from the capsule's antigen. You know what I mean? They used other ways. For example, they could have killed it. They could have used any other subunit vaccine and so on. But in the lecture specifically, she didn't mention how they created it. But in strep pneumo, she mentioned that it was created by the capsule's antigen. Makes sense why I'm kind of focusing on pneumo, because that's what she mentioned in the lecture. She didn't focus on meningitis and H influenza vaccines. Okay? Yes. So the vat capsule, I mentioned it. It's basically the glucose layer from the, or the polysaccharide layer from the outside that makes the bacteria more slippery. IgA protease. IgA is an immune kind of protein or something in the immune system that is available in our mucosal area. So for example, in our, when we swallow, our esophagus, our nose, all of the places that is exposed to the outside where it has a lot of mucus, okay, it has something called IgA protease, and IgA protease kills all foreign objects. It's perfect. It does its job and everything. But these bacteria have something that break down our immune barrier. It breaks down IgA. So it's a protease. It breaks down the IgA protein. And so the IgA doesn't work and doesn't kill the bacteria anymore because it's already killed by the bacteria's IgA protease. It breaks down the protein in the immune system. Like, what about pili? Pili is attached to the bacteria and it can send genetic information. So this can spread a lot of resistance and a lot of information from one bacteria to another, making it a big issue for us, for antibiotics and so on. Endotoxin is basically a toxin inside the bacteria that can be released and can be cause an inflammatory response in our body, which causes us to have all these severe symptoms of يعني, fever. It will have inflammatory response. Endotoxins are released, causes inflammatory response to the body, which causes this vasodilation. We have our blood pressure decreases, all of this because of the endotoxin. And that's why endotoxin can cause sepsis, where you have extremely decreased pressure because of all the inflammation that occurs due to the endotoxin. The outer membrane proteins is also used for, there are many uses for outer membrane protein here. They don't specify it, but maybe it can escape from the immune system. Maybe it can do other stuff. What you have to know is strep pneumo only has a capsule and IgA protease. H influenza and Neisseria meningitis has all of them. Okay, all of the ones we mentioned. Again, I will reiterate the concept. Strep pneumo, almost everyone, except newborns, strep B, which is Algalactiae, and Neisseria meningitis at people who are going to school from age 2 till 18. Okay, now this is a reminder of Streptococcus pneumonia. Streptococcus pneumonia is a gram-positive. That's what I remember. What is the difference from the chart you have? 19 to 60? Is strep pneumo? I don't have it different. It's the same. Oh, you mean the percentages? So I basically copy pasted the percentages from the table exactly. It's almost like a screenshot of it. So I don't know if I screenshotted it wrong or you remember it wrong. The percentages but as long as the bacteria, what I said as in terms of bacteria is right, that's what's important more than the percentage itself. But from what I have from the, wait, I'll double check. It's here with me. Since the presentation is open, let me just double check and see who's right. Okay, so I am right. 60-year-olds is 70%. 19 to 60 is, oh, I am not right. You are right. Okay, apologies. Thank you for the mistake. I will correct the presentation now. So it is كده mistake. Strep pneumo for 60-year-old is 70. From 19 to 60 is 60. Okay. Okay, thank you so much. Thank you so much, Meda, again, for bringing that to my attention. So yes, percentages, this is the correct percentages. Okay, Streptococcus pneumonia, we said it's gram-positive diplococci. And it's catalase negative, okay? So it doesn't have the catalase It can't, يعني it doesn't have the actual catalase enzyme. It's soluble, so it can live in bile salts. And oxygen susceptible. What means oxygen susceptible? Oxygen susceptible means it's able to, يعني it's sensitive to the antibiotic oxygen. We can see over here through the zone of inhibition over here in strep pneumonia, okay? We can see that it is oxygen sensitive. Over here, it's catalase negative. There's no formation of bubbles in this case because it does not have the catalase enzyme. Something else you have to know is that it is biosoluble, meaning it can live inside soluble freely. It won't die. It can live and it won't have any issues. But just something special about pneumo is that infection in patients who don't have a spleen are at very high risk. So another example I want you guys to remember so that you can relate. For example, my friend, she has sickle cell anemia. And with sickle cell anemia, they have an issue of splenomegaly. Their spleen becomes big. So she went to the doctor. She had a protrusion in her back. And when she had this protrusion, basically they indicated that she has splenomegaly, which is very associated with having sickle cell anemia because it's a very common يعني, combination of the two. But actually they said if it's not causing you severe pain and you can handle this pain where you have this protrusion, it is recommended that you keep the spleen, even if it's enlarged, because you are already immunocompromised as a sickle cell patient and you don't want to be at high risk of like things like streptococcus pneumonia that can lead to meningitis eventually. Okay, so I want you to put this example in your head that my friend, she isn't able to remove her splenomegaly or her enlarged spleen because it's not as severe, and she will be at more risk of infections like streptococcus pneumonia that can become very life-threatening without the spleen. Okay? Now, Streptococcus agalactiae. Streptococcus agalactiae is a gram-positive cocci in chain. So again, it's gram-positive cocci in chain. This was diplococci. This one is cocci in chains. And I want you to notice the difference. Over here, this is how it looks. Sorry. We don't have a picture in Streptococcus pneumonia. Okay, but it should be very similar to Streptococcus agalactiae because anyways, they're strep A and strep B. They're like sisters and brothers. Okay, this is also known as group B strep. So they're gram-positive cocci. I want you guys to notice how it looks. It's in chains. It's catalase negative. Again, similar to its sister. Okay, it's CAMP test positive. And I don't know if you remember this from POD, but CAMP test is when you put Staphylococcus aureus in the middle as a strain. This golden line is Staphylococcus aureus, okay? And when you put a strand of strep B next to it, it grows. It loves Streptococcus, Staph aureus. It loves it, okay? So when you put it, it has the camp factor, and we have the camp factor, it grows more and more. But the bacteria that won't have the camp, like they don't have the camp enzyme or they don't have the camp يعني property, they won't grow. So this is negative. They won't see growth. This would be positive because there is growth. They're growing towards Staphylococcus aureus because they love it. So this is something unique about Staphylococcus agalactiae or group B strep. It colonizes the genitals and gastrointestinal system, and 1 out of 4 pregnant women carry this organism. Okay, so newborn acquired infection because usually it is acquired from the vaginal canal when they give birth. Risk otitis media and diabetes. People who are special other than newborns who are through the vaginal canal, they get algalactiae from their mothers. The people who have otitis media and people who are diabetic are at higher risk of getting streptococcus agalactiae than the rest of human. So if you see who are at risk of streptococcus agalactiae, diabetes mellitus. I saw this in MCQs, so please have this in mind, okay? What else? Oh, okay, guys, you know that 1 out of 4 pregnant women carry this organism. Like, how do we prevent this? What do you think? What's the prevention for this in order for babies not to get streptococcus agalactiae during vaginal birth? Okay, no guesses? So it's gonna be giving them prophylactic. Another example of my family members, Allah يحفظهم لي, because they're full of examples. My cousin giving birth, every birth she has, she needs to take prophylactic because it seems like her colonization for strep algalacti in her vaginal canal is always giving a higher risk of her children getting algalacti. For the past two births, she's been taking prophylactic antibiotic a month before, I think 2 weeks before giving birth. So this is another example. I don't want you guys to remember prophylaxis to avoid algalacti. Okay? Um, I thank you guys for interacting with me. I did the OSPI review and really anyone who is replying, I feel so much like I'm talking to people with me. So please keep up the كده energy with me. Thank you so much. Okay, now Listeria monocytogenes. The unique thing about this is that it's contaminated. They'll always bring a scenario. A pregnant woman was trying to eat healthy and she decided to take unpasteurized milk from the cow عشان يكون healthy, no preservatives. Immediately, Listeria, don't have to continue the question. Answer Listeria. They want you just from the common cases to answer Listeria monocytogenes. Okay, so something else you have to know is that it had motile tumbling sensation. Okay, gram positive, catalase positive, so creates these bubbles. Rod shape, we can see they're not cocci, they're rod shaped. Okay, they're facultative intracellular, meaning they can live inside the cell. They like it, they prefer it. Incubate at low temperatures. This is some random thing that she had in the slide, and she could prop up an MCQ question about it. So it's better for you to know this random information. She didn't mention any temperature about any other bacteria except Listeria monocytogen. How can you think about it? We put milk in the fridge. So we also put Listeria monocytogen in the fridge because it likes milk anyways. It lives in milk. So obviously we will put it in the fridge. So contaminated food, especially raw milk products, risk pregnant women, newborns, immunocompromised, and old people. So basically anyone who has immunodeficiency or immunocompromised. Something you have to know is that it grows in they don't live in the fridge, they live in low temperature or cold environments, which is the fridge basically. You'd want to put them in a cold environment or lower temperature, which is the fridge. And also, if you think about it, raw milk is put in the fridge as well eventually, right? Does that make sense? There's also something else you have to know about it is that Listeria monocytogen has a small zone of indistinct beta hemolysis, unlike Streptococca Listeria. So over here in the picture, you can see there is beta hemolysis in Listeria monocytogen. Okay, Mehdi, did you get the concept of it not actually living in the fridge, but it likes low temperature? Just like in incubation, when you actually grow it, you want to grow it at low temperature. Okay, let's go to the next. Last one I want to talk about that can be presenting with acute meningitis is Haemophilus influenza. The reason why I don't expect them to bring Haemophilus influenza in SAQ is because it decreased like there was a huge decrease in Haemophilus influenza or H influenza due to vaccines, to the point that it's so rare now to get a meningitis from H influenza because it's actually a very regulated vaccination since newborn, and even it's one of the vaccines that you have to take if you come for Hajj. And I'll talk about its vaccination program later, but actually it's extremely unique due to the decline of implementation of immunization. That's why I don't think it will be in SAQ. But just for your information, it's a gram-negative coccobacilli. Something else that you can guess from Haemophilus is that it's very tiny. You see how it's very tiny over here? It's a very unique thing about H. influenza. It's tiny, very tiny. Okay? It's fastidious and oxidase positive. It requires the growth of hemin and NAD. So it lives in chocolate agar because it has hemin and NAD. And its satellitism test is positive. What's satellitism test again? So satellitism test is having Staph aureus in the middle, okay, in a blood agar, not in a chocolate agar. But because Staph aureus breaks down the agar, it releases hemin and NAD and NAD. It releases them when it breaks down the blood. So then when it breaks it down and releases hemin and NAD, what next to it? Hemophilus influenza is able to grow easily next to it. But without it, it can't grow in blood agar. It can't break it down alone. But if you give them staph, and staph breaks down the blood agar and creates hemin and NAD, hemophilus influenza will grow. And this is called a satellitism test. So hemophilus influenza is positive for this test. Alone in chocolate agar, yes, because you already broke down and released the hemin and NAD. But in blood agar, when it's not heated agar, you need Staph aureus. Okay, what is the contraindications of LP? We already said increased intracranial pressure. What are something else that I want you guys to know about CSF? Because if they bring this question, they can also not ask you about the contraindication of LP. They can be like, oh, at what level do we get CSF? Which layer of which layer of the meninges? Which مدري. I'm trying to answer every aspect of a question. So a contraindication for LP is increased intracranial pressure. Where do we take CSF? At L3, L4. I want you guys to notice over here in this picture. Follow my my laser pointer over here. At between L3, L4 over here, or L4, L5. The more common one is L4, L5. Okay? L4, L5. Where is the conomedullaris? Because when the spinal cord ends between L1 and L2. This is where it ends. And then the dura mater and the arachnoid mater continues until S1. So between L1 and S1 is the good place to take CSF. So L1 to L3 or L3 to L3 to L4 or L4 to L5 is good for CSF sampling. What is more common? 4 to 5. Why? Because we like the middle. We like it. Number 5 is in between 10. It's the number in the middle. So we like it. L4, L5. Okay? And of course, where do we take it from? From the arachnoid, subarachnoid space. Where can we take CSF? Subdural tap, ventricular tap, aspiration. Through ventricular shunt. Why did I mention this? I know this is random, but they can be like, how can CSF be obtained? Number 1, subdural tap. Number 2, ventricular tap. Number 3, aspiration. So what's ventricular tap? You take from the ventricle, you take a stent, you go all the way to the ventricles and you take. Number 2, subdural tap. You take from the subdura. I don't know how, because it's in the subarachnoid space. It must be an option. For aspiration, through ventricular shunt is another option. Ventricular tap or shunt, okay? Tube 1 that from CSF, we need 3 tubes. Tube 1 goes to chemistry and it has to be frozen. I saw questions about this, so please focus on this. MCQ. Tube 2, microlab, room temperature. Tube 3, heme lab for cell count in the fridge. Why in the fridge? Because cells will lyse if they are frozen. They will lyse. So you have to give them the fridge. Okay? For the contraindications, you have absolute and you have relative. So relative يعني manageable. Absolute, there's no way you can do a CSF puncture. So Mada, this is your answer for you. Headache doesn't seem to be a specific contraindication that was written, okay? Maybe a headache would indicate hypertension, you know? So you can think of it like this, but as a specific contraindication, no. An absolute is increased intracranial pressure, skin infection due to puncture site. Why? Because you have a high risk of causing the infection to go inside the meninges or the puncture site. This is extremely dangerous. So a skin infection near the puncture, any size of increased intracranial pressure, hydrocephalus. What's hydrocephalus? When you have a lot of water. Hydrocephalus, you guys already know it, which indicates also an increased intracranial pressure, right? Coagulation disorder or hypotension are relative contraindications where you have to make sure you manage these situations, okay? Okay, so we talked about the two, kind of went in depth into the question. Now, what is the drug used in treating the patient? Now we're going to talk about the drugs used in each antibiotic, for each antibiotic. So in this case, we are in Neisseria meningitis. As you guys said, we would give them third generation cephalosporin. This is the recommended. If we have Streptococcus pneumonia, which is the most common one in almost all age groups, we give them both vancomycin and cephalosporin. Okay, vancomycin and cephalosporin. If you have Listeria monocytogen, you give them ampicillin and penicillin. So basically, you give them penicillins, any penicillins. Streptococcus algalactiae, think about it, the baby in the vaginal canal. Or again, now remind me, who are the two people that are at risk? Except algalactiae, except newborns in algalactiae, two groups of people. No, not pregnant. My pregnant and in the Listeria monocytogen. Algalactiae, which is in the vaginal canal. Two people are at risk. No, immunocompromised and Listeria monocytogen. Streptococcus algalactiae, we said diabetics, and we said otitis media. ولا أنا غلطانة الحين أنا شكيت في نفسي. Wait. Yes, Streptococcus algalactiae, risk factor, otitis media, diabetes, or newborn. Listeria, pregnant, newborn, immunocompromised, old people. This age group situation is the Listeria monocytogen. The unique thing is Streptococcus algalactiae, which is otitis media and diabetes. Okay. Now, let's go back to the bacteria. So we said, so I will tell you something. If in doubt, cephalosporin, Listeria monocytogen, algalactiae, penicillins. Okay? Strep pneumo, you have to give them two. Vancomycin and third generation cephalosporins. What's the most famous third generation cephalosporin? Ceftriaxone. If you're confused, just write ceftriaxone, okay? This is about, what about if you want to give them prophylactic or empirical? You're not sure what the actual species is, so you have to give them based on their age, okay? So based on their age, they have like the more common, and when you give them the more, you want to give them for that most common bacteria. For neonates or infants or less than 3 months, you give them ampicillin, third generation cephalosporin, and vancomycin or vancomycin. Okay, so you give them all three that we learned. For people who go to school 3 months to 18 years, from 3 months to 18 years, you give them cephalosporin and vancomycin. 18 to 50 years, cephalosporin and vancomycin. Okay, so basically you give all of them cephalosporin and vancomycin, except neonates, you give them penicillin instead of vancomycin. Okay? But they all work. This basically is like very like open, you know, like it's type of thing. And if you write any answer, it's going to be correct, in my opinion. طبعاً يعني, but try to follow the table. This is for immunocompromised and so on. It's just reiterating the fact, if you're immunocompromised or old or post-neurosurgery, you give them vancomycin, ampicillin, ceftriaxone, or cephalosporin. You give them three things. Okay, there are three drugs I want you guys to know, just in case they ask you, they want drugs that aren't antibiotic. So for example, when you have a bacteria, طيب, you also have an inflammatory response, right? So actually the pain you're feeling is not actually from the bacteria, it's from all the inflammation. So how do you relieve this inflammation? You relieve this inflammation by something called anti-inflammatory therapy. Anti-inflammatory therapy using dexamethasone, agent to decrease intracranial pressure, you give mannitol. And anticonvulsive, sometimes you get seizures in cases of meningitis. It's one of the symptoms in meningitis because of the increased intracranial pressure. So you can give them anticonvulsants, which are diazepam and lorazepam, to stop the seizures. Okay, so anti-inflammatory therapy, dexamethasone, intracranial pressure decreasing mannitol, anticonvulsant, diazepam or lorazepam if there's a presentation of seizures. So this is a reminder of the specific mechanism of action of beta-lactams, which is cephalosporins, cephalosporins, penicillins, gabapenins, monobactams. All of them are beta-lactams. They all have the same mechanism of actions. طيب. They inhibit the last step of peptoglycan synthesis. They bind to the active site and inhibit transpeptidase enzyme or penicillin binding protein that cross-link the peptide strands. What you can say is block penicillin binding protein, which inhibits the last step of peptidoglycan synthesis. Clear. What do they include? All the penicillins, all the cephalosporins, all the carbapenems, all the monobactams. Like vancomycin. Vancomycin is different a little bit. It's the only one that we mentioned from the options that we want to treat people and bacteria that is different. It's vancomycin inhibits bacterial cell wall synthesis by inhibiting peptoglycan polymerization at the earlier stages. Okay, so it inhibits peptoglycan polymerization is the keyword I want you guys to use. Vancomycin equals inhibit peptoglycan polymerization. Beta-lactam inhibits penicillin binding protein. Okay, it binds to the penicillin binding protein or transpeptidase enzyme. Okay. Describe the prevention methods. We said my cousin, my friend's exam. Sorry, which one was it? My cousin and our example, where the pharmacy finished from this chemoprophylaxis. Prophylaxis because my cousin got meningitis. What did we take? We all took rifampicin. All the rifampicin in the eastern province, in Dammam, in Dhahran, in Qatib, all of them were done because AlZayer family and Al-Badr family had to take rifampicin. Okay, because their cousin got هذا they got meningitis. Alhamdulillah, my cousin, it's all good. And طيب, one of my cousins is diabetic. What is he at risk of? What is he at risk of? The cousin. By the way, he's the same cousin that got meningitis, guys. Exactly, strep B. The same cousin that has diabetes got meningitis. And he's the same one that we had to take prophylaxis for. So I want you guys to connect the dots. So prevention methods, vaccine, chemoprophylaxis for close contact with meningococcal meningitis, you give them rifampicin. Rifampicin, 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 please. And rifampicin is unique. Why? Because it causes red or pink tears and urine. So it's prophylaxis for close contact of Neisseria meningitis, okay? But it causes urine to tears to become pink or red, which is very crazy. So this is red tears, which is very scary. And this is urine. Can you imagine? Rifampicin is an example of a drug that causes red and pink urine. It has a lot of hepatotoxicity, so you have to be careful with people with hepatic issues or liver problems. A lot of drug interactions, especially with corticosteroids, warfarin, and estrogen, so you really have to be careful. So these are these pictures يعني summarize the problems with rifampicin. طيب, what's the mechanism of action? It inhibits bacterial DNA-dependent RNA polymerase. So it DNA-dependent RNA polymerase. So it inhibits transcription. This is the mechanism of action. Again, it inhibits bacterial DNA-dependent RNA polymerase. So you can't create RNA polymerase because it doesn't have DNA-dependent RNA polymerase. Okay, so that inhibits transcription. Like what are the adverse effects? It is also it's considered an anti-TB drug. If you get a TB case in MCQ or SQ or tuberculosis, it's chronic meningitis, you give them rifampicin. In influenza-like symptoms, so she's clearly having influenza-like symptoms. She's crying pink and red. She has pink urine or red urine. She has flushing and rash, as you can see. Hepatotoxicity due to هذا, and she has drug interactions over here. And what I mean by she is this poor girl in the picture. And I'm confused because this picture was put on Facebook and the mom is asking, why does my daughter have red tears? And I'm like, the last place you should be asking this question is Facebook. And I got this from Facebook, so this is more concerning. Give 3 symptoms that would signify meningitis. We said neck stiffness. We said Babinski and Kurgan sign. We said headache. So what else? We have photophobia, which is basically sensitivity to light, stiff neck, headache. So over here, you can see fever, headache, stiff neck, sensitivity to light, photophobia. You have nausea and vomiting. You have impaired mental status, which is that you have cranial nerve palsies that suggest involvement of the brainstem. So that if the brainstem is actually affected in this case, you would have nerve palsies. You would have petechial rash. You would have hemiparesis, which is loss of sen sensation. Sometimes is يعني irritation of the nerves and the nuclei and so on, or the loss of weakness, not loss of sensation. That would be, I mean, anesthesia. Paresis is loss of weakness, you're right. And then seizures is a possible, as we said. What would we give them for seizures? We give them lorazepam. Over here we said what was the drug we want to give them? Lorazepam or diazepam. Okay, perfect. Good job. I love the focus. Now we're going to talk about Kerning sign and Brudzinski sign. For Kerning sign is when you, يعني it's this where you basically flex the hip. When you flex the hip, and if you have a specific spasm in the hamstrings or any resistance, it indicates meningeal irritation. And the Brudzinski sign is when you pull up their neck and then they pull up their feet. Why? It's a response from pain. When their neck hurts, their legs come out because they're in pain. So this is she put up her neck and then her legs came up. This is again indicative of that she is in pain, and it's a sign of meningeal irritation. Okay, clear? So these are the examples of what examples of meningitis. Like, give 3 factors that CSF table that you guys said it perfectly. It would be turbid. It would be positive for a gram stain or a bacterial culture, not specifically a gram stain. Glucose would be low and protein would be high and neutrophils would be high. In the case of viral, it would be all normal and clear and so on. But you would have a lot of lymphocytes would also be not abnormal, يعني not as high as bacterial. Chronic meningitis would have يعني similar to bacterial. Okay, what is the mode of action of ceftriaxone? Again, remind me, guys, because we already talked about this. What's ceftriaxone and what's the mechanism of action of it? Protein binding. So it's penicillin binding protein. So it blocks or inhibits penicillin binding protein or transpeptidase. So it inhibits the step of peptide glycan synthesis, binds to the active site, and inhibit the transpeptidase enzyme, also known as penicillin binding protein, that cross-links the peptide glycan layers or peptide glycan strands. Okay, the patient was given later a vaccine. Imagine we're not talking about Neisseria meningitis. Imagine we're talking about strep pneumo. This person got strep pneumo meningitis. What's the most important part of the vaccine? The capsule. You already guys answered it correctly. Like, why? Because over here in this slide, she mentions that the preparation for pneumococcal immunization, we have PCV 13, 15, 20, and 23. All of them are capsular antigens which are conjugated either with a protein, either with a toxin, or either with or alone the capsule. So number 13 is conjugated to a carrier protein. Number 15 and 20 are conjugated to a genetically detoxified diphtheria toxin in order to enhance the immune response, even if it's genetically detoxified. BPSV23 is called the pneumococcal polysaccharide, where they're actually formulated from the capsule of the polysaccharide. Before it was the capsule's antigen. Now it's the actual capsular polysaccharide to increase the immune reaction. Okay? Yalla, next. So I want you guys to focus on the word capsule. Okay. meningococcal vaccine. Now I'm gonna give you guys an overview of like the vaccines of other things that aren't necessarily capsular vaccine. So meningococcal conjugate vaccine covers serotype ACYW135. Meningococcal C covers C alone. Meningococcal serotype B is licensed in 2015 for 3 major proteins found on the meningococcal bacteria, and then no vaccine for X. So we have a vaccine for ACYW, we have one for C alone, and we have one for B because B was discovered recently. X, we don't have a vaccine for it. Meningococcal vaccine is given part of the routine childhood immunization. How do I answer the question? Do we write all of this? No, 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 no. Just say the most important part of the vaccine is the capsule. The word would just be capsule or polysaccharide capsule. Okay. So it says, yeah, so it's a routine childhood immunization in Saudi Arabia. Meningitis C conjugate vaccine is part of the routine for the UK. Young adults from 20 to 44 are recommended. Why? Because we said meningitis, Neisseria meningitis is common where? In crowded places. And a very, very common example they bring is dorm rooms in college. That's why it's recommended for first-year college students to take the vaccine, because it's actually very common because of the crowdedness of dorms. Okay, so I want you guys to create that connection. Why do we give them at age 20 to 24? Because they go to university and they have a high likelihood of being in crowded places, especially in college dorms. Okay, vaccine is recommended in travelers to countries with epidemic meningitis and compulsory for people going to Hajj. It's always compulsory for meningitis. For H influenza, it's reduced, as I said, very much because of the H influenza type B vaccine, because type B is the most common. Pneumo administered to chronically ill and elderly, useful for reducing pneumococcal infection and role in preventing meningitis, but yet not determined how specifically it's preventing it. Now we're done with meningitis. I'm going to give you guys just a 5-minute break in order to go over the next cases with focus, okay? Are you okay with that? Just 5 minutes. Okay. Yalla. Okay. So we're done with meningitis. Now let's go ahead and do brainstem lesion. So let me go ahead and read the scenario. A 44-year-old healthy businessman presented to the emergency room with a 4-hour history of vertigo, nausea, vomiting. He had a 40-pack-year history of smoking and was not taking any medication. There is no history of fever, neck trauma, manipulation. 3 hours later, he was developed slurred speech, numbness, and paresthesia of the right side of the face and the left side of the trunk and extremities, along with dysphagia to liquids. On repeated examination, his vitals pulse was 66 beats per minute, regular respiratory rate, 24 beats were regular, respiratory rate was 24, temperature was 36.8, blood pressure was 160/90. The doctor suspected a stroke. طبعا, as we can see, it's pretty obvious that why it's a stroke, because of a 40-year history of smoking history, right? We can see that he has a lot of presentation, but they actually give us a part 2 with a clinical examination. Right-sided ptosis and meiosis. Pinprick and temperature sensation were decreased through the right side of the face. Gag reflex was absent. Deep tendon and superficial reflexes were normal. Sensation to light and temperature and vibration were normal in all extremities. Sensation to pain, temperature were decreased below the neck and the left-sided trunk. Coordination and assessment to finger to nose and heel to shin testing revealed severe right-sided dysmetria. When sitting or standing, the patient has marked truncal ataxia with tendency to fall to the right. Okay, so this is the clinical examination. Now, the question says, which area of the brain are we suspecting in the involved case? Before we do that, let's give the reason for each of the following examinations. Which part of the brain or the whatever central nervous system or nervous system in general causes this effect, and then we can conclude what we're suspecting. And I think this is a good way to organize our thoughts. And then we're going to talk about which artery involved, the radiological test and investigations, the modified and unmodified risk for stroke. Okay, we're going to talk about these kind of lower and easier answers later. The main thing we have to talk about is the reason for each of the following examination and the area of the brain we're suspecting. And no matter, you know, how many option strokes we can have, wherever in the brainstem, in the basal ganglia, in the brain, in the so many places. So there's no way I can compile all these symptoms. So I want you guys just to follow this approach. Take these symptoms, write down the possible causes for each one, and then conclude your diagnosis. Okay? So let's do it together. Right-side ptosis and meiosis. What do you think causes ptosis and meiosis? We know that ptosis and meiosis, let me show you a picture, because and meiosis. Okay, this is ptosis and meiosis. What do you think the cause of drooping of the eyelids and constricting of the pupil? Any guesses? Horner syndrome. Yes, it is Horner syndrome, but exactly, Meda, it's sympathetic. So basically, when you don't have the sympathetic system working, you're like chilling. So when you're chilling, you close your eyes. It's sleeping, relaxing. You don't have your eyes completely open and stuff like that, and dilated pupils and so on. So when you have loss of sympathetic, your eyes become overly relaxed. There's this constriction of the pupils. They don't want to look. They're drooping of the eyelids. They just want to sleep. So you're actually losing. Let me share screen. Okay. So you're actually losing the sympathetic system. So we can say, يعني, the sympathetic pathway is broken. Like pinprick and temperature sensation were decreased on the right side of the face. Who is responsible of pain? General sensations of the face. Which nerve? Trigeminal nerve. Okay, so trigeminal is responsible. And if you remember, there is 3 types of nuclei for this trigeminal. There is one in the medulla, there is one in the pons, and there is one in the midbrain. The one in the medulla, what is it for? It's pinprick and sensate and temperature. The rest are different, a little bit different. I think vibration and two-touch discrimination is the one in the pons, and the midbrain, I'm not 100% sure, so I won't mention it. Maybe it's in the slides later on, okay? But basically, the pinprick and temperature sensations are in the specific spinal trigeminal nucleus, okay? So the answer would be the spinal trigeminal nucleus in the medulla is not working. Why? Because if you would have all the nerve is broken, okay, you would have all the loss of everything: vibration, two-touch discrimination, temperature, touch, everything. You would lose all the trigeminal aslan. So when you only have one part, it means only one part, one nucleus is broken. The gag reflex was absent. Who's responsible of the gag reflex? So it's obviously, we know vagus is responsible of the reflex. Okay. Okay, yes, perfect. 9 and 10. Okay. Vagus. Vagus is 9 and is 10, right? Can you just confirm in the chat? Yes, okay, yes. So it's vagus mainly. And so obviously in this case, we're going to talk about the nucleus. So which nucleus supplies the vagus? Or supplies the gag? Yes, perfect. Nucleus ambiguous. It's okay, don't worry about it, I'll wait. Nucleus ambiguous. So now gag reflex up is nucleus ambiguous. Deep tending superficial reflexes are normal. The deep tendon and superficial reflexes are normal, meaning which track is healthy? If you don't have problems in your muscles, in the which track is healthy and we don't have a problem in it? The corticospinal track. Because the corticospinal track, we're good. طيب. And where is the corticospinal track located? Is it in the right? Is it in the left? Is it in the back? Is it in the front? Is it in medial lateral? Actually, that's not front or back. I say medial lateral, posterior, dorsal. Do you know where? Corticospinal. Do you know where? Is it medial or lateral? Medial. Perfect. Yes, medial. So what does it indicate to you? Your medial aspect of whatever we're talking about, wherever we are, whether it's pons, medulla, or midbrain, or even هذا, or even it means that it's not internal capsule, or it's not basal ganglia, or it's not whatever, because this is spared. This specific corticospinal tract is spared, and you would have a defect in corticospinal tract if anything is above in the brain, because you would have internal capsule is affected, basal ganglia would be affected, you would have problems in the reflexes and so on. Okay, so right now we know the medial is safe, and we know anything above the spinal cord is safe, the brainstem is safe. Does that make sense why I'm saying this? Or did you get confused? Okay, so basically what I'm saying in above the brainstem, what do we have, guys? يعني in terms of lesions, we have the cerebrum, we have the I'm saying, sorry, يعني I'm talking about anything above the brainstem as a whole, not the medulla. I'm talking above the brainstem as a whole. Okay, above the brainstem as a whole, if you have a problem in the fibers, like the internal capsule or thalamus or whatever, you would be clearly seeing corticospinal tract lesions. You know what I mean? So I'm telling you that because there's sparing of the corticospinal tract, it means you're safe above the brainstem. يعني it means it's a problem. يا أما in you have a problem in the spinal cord, and it's not a problem in the brainstem, and it's not in the medial aspect, because medially we have the tract. خلاص, if you got confused, لا يعني we'll leave this and it's okay, يعني you can guess from other things. And there was only a tip, لأن the thing is now you have so many options. It's not only brainstem lesions all the time. يعني I told you, and now we're going to talk about a brainstem lesion, but in the exam, you're never going to know if it's a basal ganglia lesion. You're never going to know if it's an internal capsule lesion. You're never going to know if it's a cerebrum lesion. It's not going to be as direct as now when I'm doing a pulse session for you. So I want you to be able to differentiate from the symptoms if it's in the spinal cord or in the brainstem or in the and in the brain. So the spinal trigeminal, because it is part of the trigeminal. So I'm going to talk about the nuclei of the trigeminal more in depth in the next slide. Until I'll answer your question. And if I don't answer it, just tell it to me again. I'll answer it, okay? So for the sensation of light touch and vibration, we're normal in all extremities. So you don't have a problem in which track, light touch and vibration? Which track? Medial lemniscus. The medial lemniscus is good. Why? Because it's responsible of two-touch discrimination and vibration, and conscious proprioception. We're clear now? طيب. Loss of sensation to light, to pain and temperature were decreased below the neck and left side, trunk and extremities. What does this indicate? Loss of which track? Spinothalamic, exactly. So spinothalamic is affected, so you have loss of sensation. So if the corticospinal is not affected, then it is not above the brainstem. the corticospinal is not affected. شوفي يعني أنا I can't يعني broadly speak I can't يعني because if they specifically mention a part of the thalamus that's affected that doesn't involve the corticospinal tract, it could be not involved. But I'm saying in general, seeing all the symptoms together, it's يعني أنا قاعد أحاول أصفي الإجابات, you know what I mean? يعني it's not a rule. And I don't want to generalize it. And for example, one part, if they tell you, والله the anterior thalamic nucleus is affected, the corticospinal tract is spared. It's not in the anterior nucleus of the thalamus, you know? But it's not always like this. But I'm saying from an overview, seeing that we're talking about the body, we're talking about the spine, we're talking about the sensation of light, touch, and vibration, we're talking about pain and temperature, but you definitely don't need to think about it like this. You know what I mean? Yes, lateral pons, but that's in the brainstem. Is it clear? Like, do you know what I mean? Okay. Yeah, because first of all, you're saying lateral pons is in the corticospinal tract. You're completely right, and that's in the brainstem. That's يعني my concept. But I can't say this as a rule. Okay. Coordination assessment with finger to nose and heel to shin test revealed severe right-sided dysmetria. So this indicates which part of the body is affected. Cerebellum. Which part of the cerebellum, which nucleus is responsible of this intricate movement? Dysmetria specifically being its problem. Which nucleus? I know this is a tricky question, but يعني guess. Which nucleus is responsible? No, it's the vestibular is more for balance, and ataxia would be the problem. For like this intricate, smart thing, it's dentate nucleus. The nose to nose, the heel to shin, these detailed things is for dentate nucleus. طيب, when sitting and standing, the patient has marked truncal ataxia, which tendency to fall to the right. Which one? This is your answer. It would be the globus and the, wait, let me check. It would be the truncal, it would be the nucleus vestigii for the maintenance of the truncal balance. Okay? A vestibular is not the answer. يعني, okay. So now we can go ahead and respond to like it's lateral medullary syndrome. Why? Because the right sympathetic, because of the right descending sympathetic chain, you have right-sided ptosis, pinprick and temperature sensation, right spinal trigeminal, gag reflex, right nucleus, 9 and 10 cranial nerve, right spinothalamic tract is for sensation and temperature decrease below the neck and left side. Coordination assessment is inferior cerebellar peduncles going to the right dentate nucleus. So you have a right-sided cerebellar hemisphere. Remember, it's always ipsilateral in the cerebellum. Cerebellum is always ipsilateral. For what do you want to say posterior vermis? For what exactly? Feel free to unmute yourself, by the way. Okay, when sitting or standing, the patient had marked truncal ataxia, inferior peduncle, because it's supplied by the same, I'll show you now. Okay, brainstem. Okay, let's zoom here. Where is the inferior peduncle? It's from here till here. And from here, this is middle, and this is superior cerebellar peduncle. So if you're losing this area, the blood supply here, you're also losing for the inferior peduncle. Meda, yes, you can say posterior vermis or vestigii, both would be correct, Meda. Larib, do you get why? Because the inferior peduncle is over here. So it will be the same supply of the area here. Okay, good, good. Okay. So yes, for why sitting and standing? Because of inferior cerebellar peduncle and vermis right paravermal area for the falling and truncal ataxia. The pyramids are medially located اللي هو the corticospinal tract in the medulla, so they are also spared, so no upper motor neuron signs. And that's why I said it's not going to be a medial syndrome, it will be a lateral syndrome. And what indicates that we're not in the, for example, lateral pons or lateral midbrain is because we have the specifically we have which nucleus? The spinal trigeminal nucleus, which is located in the medulla. And over here is where we talk about it. Look, in the trigeminal, we have the spinal, what do you mean? The pyramids are spared because they are located medially. And also pyramids, yes. Also pyramids being spared indicates that we have a lateral lesion, not a medial lesion. Okay, so for the general somatic efferent, so just general sensations that you can feel, we have in the medulla, spinal trigeminal nucleus, pons, we have principal sensory nucleus, and midbrain, we have mesencephalic nucleus. For the medulla, the spinal trigeminal is for pain and temperature. Pons is for principal sensory nucleus for two-touch discrimination, vibration from the head and neck region. Midbrain is for conscious proprioceptions of the muscles of mastications and temporal mandibular joint. So this is the general somatic efferent of the cranial nerve, trigeminal cranial nerve. Does this make sense, guys? So that's why we chose the medulla as the option. That's why we said there is a lesion, because it's only pain and temperature. You don't have pain of all of them. Okay, you have pain of all of them. You can't say the trigeminal as a whole is broken. You can't say it's in the pond because we don't have loss of discrimination, vibration, and two-touch discrimination. Midbrain, you can't say because we don't have conscious pain and temperature for the face. Yes, yes, because right now we're talking about cranial nerve nuclei, because pain and temperature of the rest of the body is spinothalamic, and we know it's not spared. Also, it is located laterally. Oh, I'm lagging. How's it now? It's good. Okay, perfect. So now we talked about the nuclei. طيب, what about the specifically the special visceral efferent, which is for the like the swallowing and so on. So over here we have these come from the brachial arches, by the way, just so you remember. We have brachial efferent. First arch gives rise to the muscle of the mastication. Second arch, muscles of facial expression. Third arch is muscles of the pharynx and larynx. How can you remember this? First, we have when we're first born, first arch. When we're first born, we just masticate, we just eat. So we use muscles of mastication, we just eat. Then we grow up, we start having faces, we start laughing, we start crying. So facial expression, muscles of facial expression. Third and fourth, later when you become 1 year or 2 years old, you start talking. So use the pharynx and the larynx. Okay? So in the medulla, we have the nucleus called the nucleus ambiguus. The nucleus ambiguus supplies the muscles of the pharynx and larynx, which helps in swallowing and production of voice, and damage of the nucleus would cause dysarthria and dysphagia as well. In the pons over here, we have two nuclei. We have the facial motor nucleus and we have the nucleus of trigeminal. The facial motor nucleus is for the muscles of the face. The nucleus of trigeminal supplies the muscles of mastication. So if you have problems in the pons, you would have muscles of the facial expression. We have drooping of all the face because there's no muscles, and you would have muscles of mastications. You can't eat or you can't even move your mouth. Okay. So in terms of why, now we're talking cerebellum, why it's affected. We said in the spinocerebellar tract, sorry, the dentate nucleus is responsible of the cerebrocerebellar for the coordination of planned and skilled movement, which is the dysarthria, dysmetria, and all of these things. The interposed nucleus is responsible of correcting movements in the limbs, especially in the lower limbs. But in our case, the actual problem was the vestibulocerebellum, which is maintaining the truncal balance. And all of this is sent through the inferior peduncle. And I want to show you guys something so that you can also still connect the dots in terms of the peduncles. Apologies. Okay. New share. Okay. So as we can see in this picture, 3 peduncles. Inferior, which is the one that was broken in the medulla, so it connects the medulla and the spinal cord, contains both efferent and efferent. It sends out and gives in. Middle cerebellar connects with the pons, and it contains efferent fibers, okay? So it only receives. Superior cerebellar contains efferent, mostly efferent, so it mainly sends out information and connected to the midbrain. So what was the one broken for us? The inferior cerebellar. So it's not able to send out and bring out information. Why? Now let's talk about the blood supply. Wait, I want to skip this blood supply because over here, this is the blood supply. Okay, new screen. Yeah, you can see it. Okay. You can see my screen empty, صح? Yeah, you can see it. Okay. So we can see that the posterior inferior cerebellar artery supplies the lateral medulla, and it also supplies, obviously from the word posterior inferior cerebellar, you would conclude it supplies the posterior inferior part of the cerebellum plus the lateral medulla. So that's why it's effective. طيب, let's revise the blood supply. Since we're in the blood supply, let's revise it. What are these 2 arteries? Vertebral arteries. They bring out the anterior spinal artery, and they also bring out the posterior spinal artery. So what's the blood supply of the spinal cord? Anterior and posterior spinal arteries coming from vertebral artery. طيب, vertebral artery, what else does it give? Other than the anterior and posterior spinal artery, it gives the posterior inferior cerebellar artery. طيب, this is what's broken in lateral medullary syndrome. طيب, in medial medullary syndrome, what's the problem? The problem is both the anterior spinal artery and the vertebral artery. They share the blood supply of the spinal cord. It shares it in the medial medulla. Okay, medial medullary syndrome is the effect of anterior spinal artery, vertebral artery. طيب, lateral medullary syndrome supplied by posterior inferior cerebellar artery. When it finishes from these branches, it combines and creates the basilar artery. The basilar artery goes on the basilar groove of the pons. Okay, so what does it supply? It gives pontine arteries to supply the pons. So it gives the upper lateral pons and the lateral pons supply. So the superior cerebellar artery gives the upper lateral pons, the lateral pons gives the anterior inferior cerebellar artery. And it's exactly the basilar artery supplies the medial pons. And then if we go up, the basilar pons, the basilar artery turns into posterior cerebral artery. وبس خلاص. And then you go up, internal carotid artery gives off the middle cerebral artery and the anterior cerebral artery, creating the circles of Willis. Clear? Anyone have any questions of blood supply or want me to explain to them the blood supply? Also, just for يعني عن الضمير الميدبرين, the injury of a midbrain would be due to the posterior cerebral artery. طيب, for me it's okay. Anyone else want me to explain blood supply? Clear? Okay. Anyone else? خلاص تمام. So now we're done with brain stimulations. Oh, I just want to mention the answers for the radiology questions because they're very easy and common sense, I know, but just so that you guys know the answers. They're not as much explaining. Describe the two modifiable and two non-modifiable factors for stroke. This is all neurology lectures, okay, for neuroradiology, neurology lectures. So the modifiable is smoking and hypertension because he was a heavy smoker. He's more susceptible to getting infarcts and so on. Non-modifiable, his sex and age, because he's male and he's kind of at the age where he has يعني temp of sin 44 years old. Okay? He can't change that. Like, what would if hypertension? It's manageable with medication, obviously. Like, what would we do first to rule out CT to rule out hemorrhage instead of ischemia? طيب. What is the confirmatory? MRI. Which diagnostic will confirm the diagnosis? MRI will show a hyperdense lesion in the area where there is ischemia. We can further assess the age of ischemia by apparent diffusion coefficient. What is the apparent coefficient, diffusion coefficient? هذا all in neurology lectures. CT and MRI and what is first and what is second. Okay? طيب. MRI will show hyperdense lesion in the area where there's ischemia. We can further assess the age of ischemia using apparent diffusion coefficient of magnitude with, so what is apparent diffusion coefficient? It's measuring the water molecule in a tissue. طيب, if it's hypodense, then it's acute ischemia. So if it's dark, it's acute ischemia. If it's bright, it means it's been there for a very long time. It's a chronic presentation. Okay? Okay, is it clear, guys? Okay. We talked about artery and so again, CT for ruling out a hemorrhage and MRI for confirmation using the hyperdense or hypodense, whether it's acute or chronic presentation. خلصنا brain stimulation. Now psychiatry. This is very easy, and even I'm gonna be honest with you, I don't have much explanation because it's just like you know or you don't know type of thing. A boy half naked and in the winter was caught by the police alone. Guys, just okay. A boy half naked and in winter was caught by the police walking alone at night. The police took him in station and reported that he has been hearing voices that are telling him that his family are plotting his death or killing him. He has reported seeing blood in the wall. When the police questioned him, he seemed as if he were here talking to the sky. His family reported that he has been hearing sounds for the past year, 1 year. His performance in school has been declining. Okay? So what are the keywords? Keywords are دقيقة علق معلش. Yeah, so the diagnosis is schizophrenia, but let's like يعني notice and he's half naked, he's hearing voices, he sees blood on the walls, and it's been for a year and his school performance is declining. Give 3 differential diagnoses. Okay, yes, so hallucinating, delusion, hearing voices, perfect, guys. Give 3 differential diagnoses. We might get psychiatry in it. Yes, it is يعني for us, I got it last year. Last year we got psychiatry. I think, I'm not sure. Give 3 differential diagnoses. So what are the diagnoses that involve hallucination and delusion? 3 things that involve these symptoms. Not يعني schizophrenia is one of them, you're right. عندنا delusion disorder عندنا. Not necessarily dementia. Schizoform, exactly. So these are all options. Name two types of hallucination that the person has been experiencing. You already have said it. Hallucinations and delusions. Two types of symptoms that are hearing voices, sorry, and seeing things. That's the type of two type auditory and visual. Yes, sorry. Hallucinations, auditory and visual. Name two symptoms that are required to diagnose a patient with schizophrenia. لازم يكون they have like you guys said, hallucinations and delusions. Hallucinations is hearing voices and seeing things that aren't real without any stimulation. And delusion is يعني creating scenarios. Like in this case, he was believing that his parents are planning his death. And yes, they have to, but he's asking specifically about two symptoms, not like criteria. But you're completely correct. In terms of criteria, it has to continue 6 months in order to call this schizophrenia. What type of delusion was the person experiencing? There are 5 types of delusion. I don't know if you guys remember them. When I was preparing the presentation, I completely forgot about them. If you don't remember them, it's okay. I'll mention them now. So it's like he's talking about the types of delusion oh so sorry. والله معلش الحين طيب كيف؟ I'll try to, I don't know if it's gonna be, I think is it good now or is it manageable? Okay, she's fine with me. Good. Alhamdulillah. So what type of delusions was the patient experiencing? So basically, it's talking about like, when he mentioned some people with schizophrenia believe, oh, someone's in love with me, or I have this illness, or someone's gonna kill me, or the police is chasing me. Um, so these are the types of delusions he's talking about. So we're gonna mention which one this is. No, it's not psychotic delusion, I think. I think it's not. Give two drugs of choice. So you give them antipsychotics, but specifically, I'm going to talk about the pharmacology. What is the definitive diagnosis? Because it's been a year, we can confirm it's schizophrenia. طيب so a brief psychotic disorder, schizophrenia or schizophreniform. Schizophreniform is basically schizophrenia, but less than 6 months. So I think it's like 1 month or something. Name two types of hallucinations, visual and auditory, like we said. Name two symptoms that are required, hallucinations and delusion. Hallucination is seeing and hearing others experiencing without actual stimulation. Delusion is belief and thought that are not true. What are the types of delusion that a patient is experiencing? Persecutory, I can't pronounce it. Persecutory delusion. Basically, he thinks that someone's gonna kill them. It's gonna kill him. So this is the type of delusion he's having. Give two types of drugs, risperidone and clorazepine. It's an atypical antipsychotic, and we're going to talk about their mechanism of action. What's the definitive diagnosis? Schizophrenia. طيب, differential diagnosis for anyone who has hallucination and delusion are these options. طيب, you have brief psychotic disorder, which happens for 1 month or less, where you experience hallucinations, delusion, or disorganized speech, and it's usually triggered by a stressful situation. Delusion disorder is when you have a non-bizarre delusion. So basically, you're not something extreme where it's unrealistic. You're a delusion about something that could actually happen, but it's not actually happening. So you're not imagining that you're in Mars, or you believe that you're a god or something like that. So this is delusion disorder, non-bizarre delusion. Mood disorder like bipolar and depression can present some type of delusion, and Parkinson, advanced level of Parkinson can experience delusion and hallucination. The reason why we can't really say dementia is another example is because you're talking about a very young boy. That's another example where you wouldn't say a very advanced Parkinson disease. Postpartum psychosis is hormonal shift after birth and may be due to bipolar disorder. Schizophrenia is obviously we're not talking about recently delivered this can't be أصلا a differential diagnosis. Um, Schizoaffective disorder is schizophrenia and depression and mania. Um, is basically a combination of two where you have 2 weeks of depression and I think 1 week of schizophrenia or vice versa. Schizophrenia form is when it's schizophrenia, but it's less than 6 months. So in the question, it specifically mentioned it's been a year. So this is why we said schizophrenia. But if it says in the question less than 6 months, or for example, 2 months, brief psychotic disorder, if it's been like a week or 2 weeks or less than a month. Schizophrenia form is when it's less than 6 months. More than 6 months, it's schizophrenia. Substance-induced psychotic disorder, when you have withdrawals from might cause delusion, tend to resolve once drug is cleared out of your system. طيب. These are the types of delusion I was talking about. We have jealous delusion when you believe their partner is being unfaithful. So this is jealousy disorder, sorry, jealousy delusion. You have grandiose delusion when you think you're like God, or you think you're like a prophet, or you think you're something really big when you're not. Persecutory disorders when you feel like someone is being feel like you're being mistreated, or someone's spying on you, or someone is planning harm on you. Usually usually they're very famous for constantly calling the police because they think they're getting killed when actually nothing is happening. This could apply in they think the FBI is spying on them or their family is trying to kill them, which is in this case. Then you have somatic delusion where you think something is wrong with you and you keep trying to look for errors in yourself. So ما عمرك تكون مرتاح. There's always something wrong with you. Aromatic delusion is when you believe someone important or famous is in love with you. For example, you believe Selena Gomez is in love with you. You believe Justin Bieber is in love with you. You believe that you're basically going on a date with them and so on. So this is aromatic, or my or erotomanic, sorry, erotomanic delusion. So some environmental factors, this is something they could ask to SAQ. What are environmental factors that can affect schizophrenia? Winter birth, urbanicity, four times due to social isolation, pregnancy and delivery complications, being on drugs, like drug use, father being over the age of 45, migration being stressed, being in a stressful situation. No, this is in schizophrenia specifically. Okay, migration, diabetes in mother, and childhood trauma. Early warning signs. I just wanted to mention this first. Flat face is very important. Oversleeping, insomnia, strange use of words, but drop of their grades is something that he specifically mentions in a lot of questions. So I wanted to mention it as well. The concept of negative, positive, and cognitive, I wanted to reiterate. So for the negative emotions, it's caused by, I think I have a error. I want to just double check. Second. Mm. Okay, yes, guys. So I just noticed and there's a presentation error, so I want to correct it before I explain. So just give me a second because as soon as I saw it, I realized and I probably has misplaced the answers. So cortical. Yeah. So I corrected it. Apologies for that. Um, Okay, so the negative symptoms are caused by decreased dopamine in the mesocortical areas. And what negative symptom is when you take away the normal thing that we have. For example, we have normal emotions where our feelings show in our face. When we're happy, it shows. When it's sad, it shows. People with schizophrenia, it's actually effective blunting, meaning they have a flat face. It doesn't show. And actually, just a reminder that schizophrenia is actually like a brain disorder where it's not mental only. It's not only issue in wiring. We actually lose cortical nerve, you actually nerve bodies and so on. So you have actual decrease in dopamine in the mesocortical area, making you very effectively blind, very and you don't reduce the ability to perform purposeful activity, decrease in pleasure, decrease in poverty in speech, and so on. And positive is when you add things. So you add abnormal things like hallucinations and delusions, and that's due to the increase in dopamine in the mesolimbic area. Okay, it's increase in dopamine in the mesolimbic area. So don't notice, please, the mesocortical is different than the mesolimbic. Limbic is where you have the hallucination and delusion. Cortical is in the cortex. You have decrease in the normal cortical things like language and thinking and cognition and so on. Cognition, poor executive functioning, trouble focus, and problem with working memory. And that's why they have problem at school. The DSM-5 is delusion, hallucination, disorganized speech, grossly disorganized behavior, negative symptoms, which yani flat face and all of these things. At least 2 out of 5 symptoms for at least 1 month. 1 or 2 symptoms have to become for 3 months. Okay. So this is the drugs that we said we were going to give them. We were going to give them risperidone and clozapine. For risperidone, it blocks both serotonin and dopamine receptors, which makes you decrease these hallucinations, the positive emotions. طيب. So first line therapy for schizophrenia. So the DSM-5, يعني this actually is what it says, but as far as I know, it's supposed to be 6 months. Now that I'll check with you, I'll check and I'll let you know. Or if you can check now and let us know, please. Check from the slides because يعني I'm taking things from summaries and this is like an actual summary, but I don't want to in the summary تكون غلط, you know? Okay, let me continue while you look for it, Mada, or if you don't want to, I'll let you know by the end of the presentation. Risperidone and clozapine. Risperidone is a blockage of both serotonin and dopamine receptor. Clozapine is blockage of D4, serotonin type 2A, C blockage, and D1 blockage. Okay, so يعني it's so much more than risperidone, but that's why it's the last resort drug because the amount of side effects is ridiculous. Okay, it's too much. That's why يعني you'd want risperidone. To be honest, I can't answer this question, Maday. I don't know why, but this is in pharma. This is like a pharma question. So I don't know. I just know the blockage of serotonin and dopamine would decrease the positive symptoms. You're right. I don't know how to answer this question. Okay. طيب, let's go ahead and go to dementia. So we're going to talk about Alzheimer's, okay? So Alzheimer's, we have 4 causes of cognitive and يعني patient comes with Alzheimer's and we'll immediately go to questions. ما يحتاج يعني long scenario, okay? And these are the pictures they give. Describe 4 causes of cognitive and memory deterioration in this age group. So he's an old man. طيب. What are like some causes of the cognitive and memory deterioration of Alzheimer's? Does anyone know? Okay, we'll go over it. It's okay. طب describe two features in the following picture. You're right, yes. Cortical artery is يعني the four causes of cognitive يعني I was talking more about in Lewy body dementia, Parkinson's vascular dementia, Alzheimer's. Maybe my question wasn't as clear because I said Alzheimer's symptoms, yeah. But I was talking about these, but it's okay. We'll go over these. But for the features, we said cortical atrophy in the frontal lobe. As we can see here, it's just much, much more gaps. And we can also see here enlarging of the ventricles because the white matter also is decreased. Describe the following histological findings. This and this. What can you see? Amyloid plaques and yes, neurofibrillary tangles. Exactly. Describe what are the most likely diagnosis? Alzheimer's. Okay. Give two drugs of choice. So neurodegenerative drugs, which we will talk about now. What patient was given memantine? What the patient was given memantine. What's the mechanism of action? We'll also talk about more in depth now. طيب, four causes: Lewy body dementia, Alzheimer's, Pick's disease. This is found in neurodegenerative diseases, vascular dementia, and so on. Describe two features of the following pictures: atrophy of the frontal lobe and atrophy of the, I think it's an NMDA receptor antagonist. Yeah. So it's not a cholinesterase inhibitor. Okay, so atrophy of the frontal lobe, bilateral dilated ventricles. So for describe the following histological findings: neurotic plaques and neurofibrillary tangles. What is the most likely diagnosis? Alzheimer's. The patient was given memantine. What's the mechanism of action? An NMDA receptor agonist. And this is the Oh, okay. So Meda just said, guys, just to confirm about the schizophrenia, it means that the symptoms of hallucinations and disorganized should be like 1 month of being disorganized, another month of hallucinations, but in total, it should be the last 6 months you've been suffering of all these symptoms. Thank you so much, Meda. Okay, so for Alzheimer's, it's two proteins. You would have the amyloid beta and tau in different parts of the brain. And the reason why is because amyloid beta is formed by the amyloid precursor protein that's cleaved by beta secretase. It should be uh, cleaved by alpha secretase instead of beta secretase, and breaking down by alpha secretase is what causes these plaques and tangles. The amyloid peptides, which in turn form fibrils called plaques, and tau phosphorylation causing tangles. This is the picture. This is kind of reiterating the fact that neuroplaques are in the extracellular collections of amyloid core, and the neurofibrillary tangles are twists of aggregations of cytoplasmic fibrils. A major component is hyperphosphorylated tau proteins. Okay? And the diagnosis, we said, generalized or focal cerebral atrophy, enlarged ventricles. We can see the difference between the enlarged ventricles and the generalized focal or focal cerebral atrophy, narrowing of the gyri and pomadine sulci, a disproportionate atrophy of the medial temporal lobe, including the hippocampus. Increased tau concentration in the CSF is also something that you can find. That's basically it for يعني Alzheimer's. The greatest known risk factors: increase of age, and the majority is Alzheimer's are 65 and above. It's associated with cortical atrophies, neurotic plaques in the extracellular regions, neurofibrillary tangles, and the intracellular lesions. And these changes result in neural dysfunction and neural death and inflammatory reactions. And Alzheimer's is 60 to 80% of dementia. And that's all. We're basically done. We're done with the presentation. So the other high yield neuro cases, I don't think I should go over them because they're not question based, and they're just, I put all the pathology cases of neurodegenerative diseases because it's يعني also possible pathology questions instead of Alzheimer's, you know what I mean? So it's not realistic for me to go over every single degenerative disorder. And so I couldn't write every question, a question for each. So I wanted to just include them as for you guys to know that they're possible SAQs, maybe. But yeah, not what I saw in practice questions. So that's it for me today. Inshallah, this was helpful and it taught you a little bit about how SAQs can form. One thing I want to mention is I want you guys to go over ischemic or hemorrhagic stroke. I didn't get the chance to add it in the presentation, but it is also a possible case scenario that I didn't put in the pathology because it's considered an anatomy lecture. So hemorrhagic stroke or ischemic stroke, please mention, go over them. It can be a possible SAQ, but I try neuros endless. No matter how much I mention, there will always be something missing. Good luck, everyone. Inshallah, this was beneficial. Please give me feedback and growth and development feedback using this code. I'd really appreciate it so that I can كذا improve. وبس والله. Good luck ومرة ثانية كل عام وانتم بخير و good night everyone.